Recording in progress.
Somnath sir, should I start?
Yes, I think you can start.
So the duration of exclusive breastfeeding, there is no change in recommendations. It is still till 6 months of age. However, there are issues like working mothers, issues with maternity leave, nighttime feeding, and father and partner support that could have issues regarding exclusive breastfeeding till 6 months of age. Now, regarding choice of milk, there is no change. If mother's own milk is available, it is the best. Not available, then donor's human milk. Not available, then preterm formula should be used. And regarding the recommendations on infant formula, the previous recommendations stated that if in VLBW babies who cannot be fed on mother's milk or donor human milk, then standard infant formula can be used. These recommendations are relevant for resource limited settings where preterm formula, specific preterm formulas may not be available. And that previous recommendation stated that only if the preterm infant failed to gain weight on standard formula, then only specific preterm infant formula to be used. However, the current recommendation states that for preterm neonates less than 32 weeks gestation or VLBW babies, nutrient-enriched preterm formula may be considered. Regarding the difference on multi-component fortification, it was not recommended, should not routinely be given, and only those who fail to gain weight, VLBW babies, and only in those babies it was recommended. However, in the current recommendation, it is not routinely recommended in all LBW babies, but for very preterm, that is less than 32 or VLBW babies, it may be considered. And when and how to initiate feeding, there was no sense. The infant should be put to the breast as soon as possible after birth, and minimal enteral nutrition to be started as early as possible. Regarding optimal duration also, as I stated, there was no sense. It is still till 6 months of age. And how to feed, then there is no new recommendations here. Those who need to be fed by an alternative method can be fed by cup or spoon. Bolus intermittent feeds are preferred as far as the feeding guidelines of 2011. In VLBW, infants would need to be given intergastric tube feeding. The choice is on the healthcare providers whether they want to use the oral or the nasal. And as I have already stated, in the previous recommendation of 2011, those LBW infants should be fed based on infant's cues, except when the infant remains asleep beyond 3 hours. But in this current recommendation, they have stated that scheduled feeding may be considered rather than responsive feeding for infants born less than 34 weeks gestation. But for more than 34 weeks gestation, whether scheduled feeding or feeding based on infant cues to be used, it is upon the decision of the physician. And regarding the maximum increase of feeds, that is 30 ml per kg per day, there is no change. Regarding micronutrient supplementation, iron supplementation is recommended for human milk-fed preterm or LBW infants who are not receiving iron from another source. Based on most of the trials, the recommendations suggest a daily dose of 2 to 4 mg per kg per day. It may be initiated when enteral feedings are well established and may be continued until the infant receives iron from another source. Regarding zinc supplementation, enteral zinc supplementation may be considered in those LBW infants who are not receiving zinc from another source, dose based on most of the trials, a dose of 1 to 3 mg per kg per day is recommended. And zinc supplements are often provided as either 5 mg zinc capsules that are opened and mixed with 5 ml of water, giving 1 mg elemental zinc per ml, or zinc containing multinutrient syrups where 5 mg elemental zinc is there in 120 ml, that is 42 microgram elemental zinc per ml. Vitamin D supplementation, it may be considered in those human milk-fed preterm or LBW infants who are not receiving vitamin D from another source. In the remarks regarding this recommendation, it has been seen in the trials that by giving vitamin D, there is improvement in vitamin D deficiency and alkaline phosphatase, but there were no data on other markers of bone health such as osteopenia or rickets. And based on most of the trials that were included in the systematic reviews, the guideline developmental group suggests a dose of 400 to 800 international unit vitamin D for these VLBW infants. Regarding vitamin A supplementation, it may be considered in those less than 32 weeks gestation or in those babies who has birth weight less than 1.5 kg. It is a conditional recommendation. For more than 32 weeks or more than 1.5 kg, there are no clear-cut recommendations. A daily dose of around 1,000 to 5,000 international unit is suggested according to these guidelines. And 2 trials that were included in the systematic review provided this vitamin A supplementation up to 28 days, and 2 other trials continued this vitamin A supplementation up to 34 to 36 weeks post-menstrual age. And so that could be the guiding factors, but WHO itself doesn't give any specific recommendations when to stop vitamin A supplementation. Regarding calcium and phosphorus supplementation, no recommendation. Multiple micronutrient supplementation, no recommendation. So the important differences being vitamin D in the previous 2011 guideline, 400 international unit to 1,000 international unit till 6 months. Here, 400 to 800 international unit per day. Regarding calcium and phosphorus, as I've already stated, no new recommendations. The previous recommendations suggested 120 to 140 mg per kg per day of calcium and 60 to 90 mg per kg per day of phosphorus. Iron 2 to 4 in the earlier recommendation, as well as 2 to 4 in the new recommendation. But one important thing is that in the earlier recommendation, it was specifically recommended for VLBW infants less than 1.5 kg, but in the new recommendation, it is for all preterm and LBW that is less than 2.5 kg. So that is one difference. Another one is that in the previous recommendation, there was no recommendation for vitamin A, but here for less than 32 or less than 1.5 kg, there is a recommendation. And there was no recommendation for zinc in the earlier guideline. Here, they state that it may be considered in those VLBW infants who are, or all LBW infants who are not receiving zinc from another source. So here, I would like to just in this particular table, would also like to give the specific differences between the recent ESPHAGAN 2022 recommendation and the current WHO recommendation. The values slightly differ, as can be seen in the table. One important point here is that in the WHO recommendation, in the ESPHAGAN 2022 recommendation, the dose of vitamin D is 400 to 700 international per kg per day. So here the weight of the infant is also taken into consideration. But in all other recommendations, it is directly stated as international unit per day. But this new ESPHAGAN guidelines also take into consideration the weight of the baby. And the maximum, they have suggested that it is should be up to 1,000 international unit, irrespective of the weight. Regarding probiotics, there is a new recommendation, was not available in earlier WHO recommendations. Should be considered or may be considered in those human milk-fed infants less than 32 weeks gestation. And for infant-fed formula, there was no recommendation because only 5 trials were there. Regarding type, formulation, dose, timing, and duration, there were no specific recommendations because there was insufficient evidence. In the 33 trials that were used in the assessed in the systematic review, they used single genus probiotics, most commonly Bifidobacterium or Lactobacillus. 23 trials used multi-genus combination, most commonly Bifidobacterium plus Lactobacilli. Most trials initiated these probiotics during the first week after birth, typically with the first enteral feed. In most trials, the intervention was at least for 6 weeks, typically lasting till discharge from hospital. One trial continued the intervention till the infant reached 2 kg body weight. So these are some of the guiding factors that could help us decide up to what duration we should be using the probiotics. In our particular unit in our hospital, we are using this new Derolic sachet, which contains where 1 gram contains probiotic of around 1.25 billion cells. It contains Lactobacillus acidophilus, Lactobacillus rhamnosus, Bifidobacterium longum, and Saccharomyces boulardii. We have noticed the decrease in feed intolerance, but we do not have strong evidence because we have not carried out any RCTs or anything regarding that. But we have found that there is a decrease in feed intolerance when probiotics are used. So justification was evidence of moderate benefit regarding decreased mortality, NEC, and invasive infection. So these are the justifications for these new recommendations of probiotics. Emollient, new recommendation, emollient may be either oil, ointment, or cream. There is no recommendation for ointment or cream, but there is a recommendation for oils. And they have suggested that sunflower or coconut oil may be used because only these oils were used in most of the trials. And they've also suggested that these oils should be applied gently to avoid disrupting skin integrity. Now, care for complications. First, CPAP. First is updated one. Here, CPAP is recommended in preterm infants when clinical signs of respiratory distress syndrome are present. This was also there in the previous recommendations. This is not a new recommendation, but the guideline developmental group strongly suggests that CPAP implementation must be done with skilled staff, quality equipment, and quality consumables, and including humidified blended oxygen air monitors. This is a new recommendation regarding CPAP, where they have stated that CPAP should be used immediately after birth in less than 32 weeks gestation, irrespective of the presence of respiratory distress. So they suggest that even if a baby does not have respiratory distress, then also CPAP should maybe considered in less than 32 weeks gestation. It is a conditional recommendation. Justification they have given is that it can be difficult to ascertain respiratory status in preterm babies soon after birth and to accurately predict which babies may deteriorate. So this new WHO guideline suggests that even if respiratory distress is not present in less than 32 weeks gestation, we can consider giving what may be called as prophylactic CPAP. Regarding another guideline for CPAP, which is also new, regarding the source of CPAP, they have suggested it is a conditional recommendation that bubble CPAP may be considered rather than other sources of CPAP like ventilator or infant flow divers CPAP. They have suggested here that bubble CPAP may be better, but they also suggested that nasal interfaces, prongs, and cannulas should be carefully selected and skilled nursing care is needed when CPAP is used. And only commercially available bubble CPAP devices should be used. Locally manufactured or locally adapted bubble CPAP devices should not be used. So regarding bubble CPAP versus other CPAP pressure sources, from the systematic review that they have used in this particular recommendation, they have just given evidence of small to moderate benefits when bubble CPAP was used regarding decreased pneumothorax, decreased BPD, decreased failed treatment, and it was, however, it was of low certainty evidence. However, whether to use bubble CPAP or ventilator CPAP has a lot to do with the resources that are available in the particular unit. But this particular recommendation for WHO from WHO strongly in favor of bubble CPAP. So regarding CPAP, the changes being the one that I have already stated, the immediate CPAP, where babies even without respiratory distress is put on CPAP. There is a conditional recommendation, it is new. And another new one is that bubble CPAP may be considered over other sources of CPAP like ventilator. Regarding surfactant, the recommendations were there in 2015. No new recommendations here. So already the existing recommendations still exist. Regarding oxygen therapy, no new recommendations. The earlier recommendations of 2015 are still there. We're in less than 32 weeks gestation. We should start ventilating with 30% oxygen or air if blender is not available. We should not use 100% oxygen. And if the heart rate is less than 60 beats per minute after 30 seconds of adequate ventilation with 30% oxygen on air, only then we should start considering titrating the oxygen, FiO2. And adjustment of FiO2 should be at steps of 10% every 30 seconds. But however, there are no new recommendations regarding that. Regarding methylxanthines, there are 3 recommendations. All of them are new. First one, for treatment of apnea, it is recommended for the treatment of apnea in preterm infants. They have not stated less than 34 weeks. For all preterm infants, caffeine is recommended for treatment of apnea. It is a strong recommendation, moderate certainty evidence. Dose is 20 mg per kg loading dose, 5 mg per kg per day maintenance for 6 weeks. And if caffeine is not available, then other methylxanthines may be considered. The various available formulations for methylxanthines. Next, for methylxanthine is for extubation. For extubation, it is recommended for the extubation of infants born less than 34 weeks gestation. Strong recommendation, moderate certainty evidence, but they suggest that even for those who are more than 34 weeks, that is 34 to 37, it can be considered before extubation. It should ideally be started 24 hours before a planned extubation and should be continued for 6 days. Dose is same, 20 mg loading dose, 5 mg maintenance for 6 days. Regarding prevention of apnea, again, the recommendation is for less than 34 weeks gestation, conditional recommendation. However, they suggest that even in infants from 34 to 37, it could be considered for prevention of apnea. Now, regarding the third broad sphere, that is family involvement and support, these guidelines were not available in the old WHO guidelines. The current guidelines strongly favor family involvement and support. They strongly encourage couplet care, family-centered care, involvement of other family members in taking care of the babies as well as in the decision making. So strong recommendation is there for family involvement in routine care of all LBW infants. And they suggest that simple family involvement interventions like direct bedside care involvement in decision making could be implemented in all settings. And even in resource limited or even in busy settings, chairs could be placed near the infant's cot, and reclining beds and chairs are preferable. And they suggested that family involvement reduces the length of hospital stay, improves breastfeeding, and reduces parental anxiety and stress. Regarding family support, again, a new recommendation. The family support should be there from antenatal period itself, and it should be continued during follow-up post-discharge. The support could be in various forms like education, counseling, discharge preparation, and support from peers. It is a conditional recommendation, but and they suggested that careful coordination of care is needed post-discharge of these vulnerable infants. And ideally, the support and planning should be started in the antenatal period wherever possible. Regarding home visits, again a new recommendation. Home visits by trained health workers are recommended, and it is a strong recommendation. The trained health workers could mean nurses, midwives, doctors, or community health workers. We all know that there are 4 routine scheduled postnatal contacts for every infant, whether term or preterm. But for preterm, there should be extra home visits beyond these routine 4 visits. And this how much extra or how many extra visits to make, that is upon the treating physician. Another new recommendation, this is a good practice statement because this is not backed up by strong evidences from RCTs or any such evidence, but it is a good practice statement, and the WHO strongly recommend that parental leave and entitlement should address the special needs of mothers, fathers, and other primary caregivers. It should include additional days of leave from work and additional financial payments to the families who have LBW babies. However, how many days of leave or how much payment to be made, that is not being clearly stated. And these are already in place in some countries, but recommended that and they recommended that it should be expanded globally across all the high, middle, and low income countries. So 140 countries today has policies for parental leave. 28 countries has a parental leave policy specifically formulated for preterm infants. And in most of the guidelines or policies, the amount of leave time is approximately equal to the number of weeks early that the baby was born in most cases. So if born at 34, means 6 weeks or something like that could be the number of weeks of leave that could be applicable. So the recommendation summary. So these are the summary on new recommendation: immediate KMC, another new recommendation for probiotics, new recommendation for topical oil application, new recommendation for CPAP immediately after birth, or prophylactic CPAP, it may be called. For bubble CPAP, preference over ventilator CPAP is a new recommendation. Methyl xanthines for treatment of apnea, for extubation, for prevention of apnea, all new recommendations. Here, one thing to notice that for treatment of apnea, they have recommended for all preterm infants less than 2.5 kg, not specifically less than 34 weeks. Regarding family involvement and support, all are new recommendations, and this current guidelines puts a special emphasis on the involvement of the family in decision making as well as in taking care of these vulnerable infants. Regarding monitoring of these recommendations, what could be the various parameters? The parameters could be neonatal mortality rate, early breastfeeding within 24 hours, postnatal context early within 2 days of birth, and what is the proportion of infants that are receiving KMC. So this could be some of the criteria upon which whether the success of this recommendations could be based on. Applicability issues are also there, that there is difficult access to health service and health workers, lack of human resources, lack of infrastructure, resistance of health workers to the changing recommendations, and lack of health management information systems could be some of the hindrances behind putting into effect all these recommendations. There are various research scopes in almost all the modalities, but to highlight specifically for critically ill preterm LBW infants, how this immediate KMC could be implemented is a research question. Then what could be the optimal combination of genera, species, and strains in probiotics, which emollient to use, and what strategies that we can take so that there is maximal familial involvement could be some of the research questions that could be addressed in the future recommendation. So on this recommendation, there are a few points to ponder upon, like scope and feasibility of immediate KMC in low resource settings. Concept of mother NICUs and couplet care is encouraging, but in busy settings and settings where infrastructure is not proper, how far this can be carried out is still a matter of debate. So that was all for this new recommendation of WHO, but there are few other important recommendations that have also been published in 2022 itself. These are the two important recommendations in 2022 besides the one that I have discussed. One is for antenatal steroids, another is for tocolytic. For antenatal steroid, there is no change in recommendations from those that was already there in 2015. The 24 to 34 weeks and everything is almost same. Specifically regarding the late preterm, that is 34 to 37, the ELF trial in 2016 showed some benefit, but the Action 2 trial from WHO did not show any benefit. So even in the current recommendations, the antenatal steroid is not recommended in 34 to 37 weeks gestation. So that is a scope for research. And regarding others also, there is no sense regarding antenatal steroids compared to the last recommendation. Regarding tocolytic, there is a sense. In this new recommendation in 2022, they state that nifedipine is recommended for acute and maintenance with a high likelihood of preterm birth in 24 to 34 weeks, so that it could permit a single course of antenatal steroid to be given. But contraindications are like vaginal bleeding, placental abruptcy, or intrauterine infection. But adequate birth care should be available, facilities, all those should be available. And they consider nifedipine to be the preferred drug. The dose is 20 mg followed by 10 mg every 6 hours for 3 to 7 days or until transfer. And COX inhibitors could be used up to 28 weeks, but not beyond that. Beyond 28 weeks, COX inhibitors are contraindicated. So this is a new recommendation. So the differences, tocolysis, there was no recommendation for tocolytics in the previous 2015 recommendation, but the 2022 recommendation, they say that nifedipine is recommended between 24 to 34 weeks if all the criteria are fulfilled. Regarding Maxalf, whatever the recommendation was there in 2015, there are no new recommendations. Antibiotics in preterm labor, no new recommendations. The recommendations that were available in 2015 still exist, where erythromycin is still recommended as the antibiotic of choice for prophylaxis of women with preterm pre-labor rupture of membranes. And co-amoxiclav should always be avoided. If erythromycin is not available, then only plain amoxicillin can be used, but co-amoxiclav should never be used in women with preterm pre-labor rupture of membranes because there is increased risk of NEC. Optimal mode of birth for preterm delivery, routine delivery by caesar not recommended regardless of cephalic or breast presentation. So the mode of delivery is based upon obstetric indications. There is no recommendations regarding preterm birth. So this is a basic summary of all the current WHO recommendations that exist for the preterm or LBW infants. In this particular recommendation, KMC is there, feeding, micronutrients, probiotics, emollients are there, CPAP included in this guideline, methylgentins included in this guideline, familial involvement and support newly included in this guideline was not there in the earlier WHO guidelines. Regarding other areas of concern, it is either present from before or certain guidelines will be forthcoming in the new WHO guidelines. So various WHO guideline resources. This is the resource that is available where almost all the areas concerning preterm growth or growth of newborn or regarding our newborn infants is covered. So these are the various WHO recommendations that we can go through to find out the latest WHO recommendations to improve preterm as well as term birth outcomes. So take-home message is that in this new recommendation, family-centered care has been focused upon, and it is the way forward. It reflects a fundamental change in the way care is conceptualized and should be provided in the future. However, implementation of these recommendations requires changes both in attitude as well as infrastructure. However, if we can successfully carry out these implementations, then it is likely to transform maternal and newborn healthcare delivery across all countries, irrespective of high income or low income settings. Thank you.
Thank you, Rajib. It has been nicely presented. The recommendations given by WHO for improving the preterm birth outcome, and he has nicely presented various guidelines regarding the prevention, complication, and the family support. And he has also compared the different guidelines, the earlier guidelines, the present guideline, and even the ESPAGAN 2022 guidelines. Now, in this year, we have seen a lot of several guidelines, and it is one of the important one to improve the preterm outcome. So now we can have a look at the chat box and we can answer the questions the participants have. So one of the participant has asked what is the dose, duration, and timing and initiation of Darolac that you might be using in your unit. So Rajib, can you answer this question?
We are using half cc BD, and we are basically adding this Darolac cc from either the first feed or when the baby has reached 20 to 30 ml per kg per day of feeds.
Yes, yes, that is our unit policy, but it has to be mentioned that there is no single recommendation, and most of the studies favor multi-component probiotic supplementation, such as that we use in our unit, which is a combination of lactobacillus, bifidobacterium, and Saccharomyces. But still, then there is no specific recommendation, and we use from the first dose itself if it is possible, and if not, as early as possible, and we continue till the baby is 35 to 36 weeks of age, and we give it in a twice daily doses. Meta-analysis has been published, and still no definite answer has been found till date, but that is our recommendation. So the next question. So next question is, can we use early total enteral feeding in VLBW babies with respiratory distress? So Rajiv, your opinion in this matter?
Sir, this is a if the baby is hemodynamically stable, ideally we should be able to give, but in our unit we have seen that in VLBW infants, if we go for full enteral feedings on the first day, most of the babies do not tolerate. However, if the baby is hemodynamically stable, the guidelines do not suggest restricting feeds even from the first day.
Yes, there has been controversy, and there are some recent studies which support starting full enteral feeding even in VLBW babies from the very first day. But that thing needs I think more evidence before we can implement in our routine practice. Now it is seen there are some studies which shows beneficial effect in terms of reducing hospital stay, reducing feed intolerance, increasing weight gain. But in our experience, what we can see that if you start full enteral feeding in VLBW babies, and then we land up into feed intolerance after 1 or 2 days. So in our practice, what we start if the baby is VLBW, and maybe in NIC we start with minimal internal nutrition, and then we gradually increase the feed once it has been tolerated. But still it is open to debate, and it is open to further research, and still there is no definite recommendation, but that is what we follow in our unit. So are there any questions? And if there is any question, you can write it down in the chat box and we can answer it. So one thing I want to say, in fact, that preterm birth outcome can not be improved by only a single domain. So it has to be started from the antenatal period, and from the delivery, from the labor room, from the nutrition, from the family support, from the KMC, from the discharge, even follow up, and and even the routine screening such as ROP screening and the IV screening, PVL screening, everything. So preterm is a preterm birth, and the complications of the preterm birth is a big umbrella, and for which you need to consider several aspects, and with a single recommendation this cannot be managed properly. So these are only a part of a bigger problem, and that has been given by WHO, but still there are new evidences are coming, and we need to change our practice accordingly. But what has been given so far, it has been nicely presented. So in case, is there any other question? So I don't think so. There is no more question. So I think we can wrap it up for tonight. And Rajiv,
Yes, yes,
thank you very much for your
yes.
wonderful presentation.
Hey, thank you.